Great. Thank you. So really excited to be here today with everyone and talk about the work that we do at InquisitHealth, which is really around, which has brought up some of the themes that we focused on and how we can utilize a tech-enabled workforce of mentors. And by mentors, I'm referring to essentially remote community health workers who have lived experience, who can help us address loneliness, who can help us address other social determinants, and who can help us address the underlying physical health that all really comes together in one package when we're dealing with many of these patients that are very vulnerable and need our help. And so before diving into kind of what exactly InquisitHealth does, one of the things that we have learned and we've been excited about as the field has rallied around this idea of social determinants of health, we have seen that referrals to social services are critical. Someone with diabetes, if they have food insecurity, connecting them with a food delivery service is essential. But what we often find is that it's not the full solution to addressing their poorly controlled diabetes or hypertension. At the same time, we realize that behavior change is critical. We need to help individuals activate these healthy behavior changes. We want to help someone remember to take the medications regularly, but that's also not enough if they can't afford the medication in the first place. And so the approach that we've taken has been really thinking about the social determinants of health and what we started calling the behavioral determinants of health, really thinking about them together as necessary to address in tandem to drive lasting improvements in clinical outcomes. And so when it comes to loneliness, I think tongue-in-cheek, we don't want to address loneliness in isolation. We realize that our patients, and so this is pre-COVID and including COVID, we see that 25% of the patients that we work with that are poorly controlled diabetes or hypertension also have loneliness. And so mentoring for us is focused on addressing the social plus behavioral determinants of health, which includes loneliness as a part of that overall approach. And the way that we do this is by and through a carefully chosen trained mentor who is matched with somebody based on shared attributes. And I'll talk more about this, but important things like language, community and culture, common lived experience are all critical to establishing that shared empathy. And then where appropriate, then escalating and involving the clinicians, the CBOs, the health plan and health system resources to make sure this is really kind of loneliness and the broader array of issues that surround loneliness are not addressed in isolation, but really as part of an entire team. So a little bit of background on InquisitHealth and our origin story. So looking at the data, multiple randomized clinical trials that have demonstrated the efficacy of mentors in a clinical setting, in a research setting, what we did was utilize that as a basis to approach the NIH, which funded us to really build three technology-enabled components. First is a training program. So how can we take individuals from the community and train them to become mentors such that they're able to help other individuals? The second piece is a mentoring platform that says, hey, here's this remote workforce that you've now activated. How can they be connected with the patients that need their help? And how can those individuals provide that one-on-one support and mentoring and coaching? And then the third is, we don't want this to exist in isolation, but really part of an entire team. And we want to make sure that these interactions are happening, but they're also driving improvements in clinical outcomes. And then as appropriate, additional clinicians, CBOs, et cetera, are tied into that process so that it's a seamless experience for the patient. And so we've pulled these pieces together for our health system and health plan clients. And we think about this as mentoring as a service, really trying to make it as turnkey as possible. And we built programs specifically focused on improving clinical outcomes in diabetes, prediabetes, asthma, HIV, sickle cell, and hypertension. And these physical conditions are our focus area, but all of them have the underlying social determinants of health that need addressing in addition to the behavior change components that we work on. And so all of these programs are really two core components. There is a technology piece that really is focused on how we make this work in a turnkey way for a health system or a health plan. And so how can we, this is speaking to our capabilities, and this is highly customized by the partner, but thinking about how we can reach these patients that need additional help and support. Then how can we understand their challenges and pair them with a mentor? And how can that mentor then work with the patient over multiple weeks and months to be able to address those issues that have been uncovered? And then lastly, like I talked about, how can that mentoring be connected to the other issues and challenges that this patient is having, and the resources that are available in the community with the health system, with the health plan, that need to be working together to help address these issues. And so in addition to that sort of technology infrastructure, the core kind of secret sauce in driving that empathy, driving that understanding, building that context, and driving the improvements in clinical outcomes is this workforce. We call them peer mentors. These are remote community health workers. They're from the community. They often live with the same chronic condition as the patients that they're working with. And they've been trained by us to be able to help engage and support these other patients. And I think 2 points I want to highlight here. One is that the diversity of the mentors is critical because they reflect the diversity of the patients that we serve. And this is especially critical as we're trying to reach and help support patients in various communities, and especially in conditions like diabetes and hypertension where diet is a key factor. This is something that we need to take into account and leverage really to make sure that these programs that we're putting in place are efficacious. And then the second piece is that these mentors are working with us part-time remotely from home. And so this is an opportunity for them to supplement their income. But on the other hand, it really provides high weekend and evening availability, which sometimes plays really nicely to augment the existing efforts of a care management program at a health plan, for example, or a PCP office that's only open during the day, and really activating this workforce cost effectively to provide really a lot more support to individuals over time than might be typically possible with the existing resources that a system might have. And so we are happy to work to share that we're working with a number of partners, Medicaid plans like Metro Plus and Health First, public hospital systems like New York City Health and Hospitals. One quick point there is that during COVID, our program is entirely remote. We've been working with them. And while we were at, New York was at ground zero, we actually increased our footprint with them and started working with a hospital that was really at ground zero as a function of realizing that these patients are struggling even more as a function of COVID. And this type of approach of utilizing these remote community health workers or mentors was critical to be a part of the overall strategy to address COVID, but also the other implications of COVID as a function of, diabetes didn't go away, for example, and really utilizing the resources and capabilities that have been built so that it can be activated during this critical time. And so we work with partners here in New York, where we're based out of, but also as far as Alaska. Now, a couple of things I wanted to share is that in these implementations across the spectrum, we have seen that peer mentoring is engaging and efficacious. We've seen a high amount of engagement for the patients that we approach that need our help, and high over 80% enrollment, over 200 plus minutes of engagement per patient over the phone, in addition to everything else that I'll talk about, which is key. And then we've seen clinical outcomes in terms of over a point reduction in hemoglobin A1C across a broad base of patients, and then improvements in systolic and diastolic blood pressure, as well as increasing in monitoring. Now, what I wanted to spend a couple minutes really just talking about is how we've thought hard about, this is a great idea, this makes a lot of sense, but how can this practically work with a health system or a health plan that is already doing a lot of things? How can this augment those efforts to be able to really serve as an extension of the existing resources and allow those resources to work more optimally, ideally? And so, again, this is speaking to capabilities, and we've dialed this up and down as needed, but these partners of ours are sharing with us, hey, these are patients that we know need more help, maybe because of a high blood pressure reading, maybe because it's a high A1C reading, et cetera. And so we've developed a system to be able to reach out and engage these patients in the language that they speak, to be able to understand and start seeing how we can help those specific individuals. And so this begins by us understanding the 1 level, 2 levels, 3 levels deeper in terms of what's actually going on. So the A1C is high, and through these survey sets, we're able to understand what's the social determinant that may be going on, what are the behavior change components, and really bucketing them as issues that need to be addressed, and then having tracks that are deployed sequentially in a intelligent way to help make it easy for the mentors to be able to address these issues systematically and together as appropriate, and then really breaking it down to steps so that individuals, the mentors can do their role, the experts that I'll talk about can play their role, referral partners, really everybody can work together to be able to address the issues for the patient in a way that's seamless, but it all begins with this assessment that's critical. The second piece is the mentors are individuals, like I said, from the community, individuals that want to spend a lot of effort in terms of, and we do spend a lot of effort in terms of finding the best fit mentor to work with each specific patient. And then that mentor with that game plan, with that pathway, they're able to deploy the mentoring. And so this is custom based on that individual's specific issues. And one point that I wanted to make here is that the modality of mentoring has, we've been very, very flexible and without compromising efficacy. And so at the minimum, all somebody needs to participate is a phone. And that allows us to deliver our mentoring. And then if they have a smartphone or if they have SMS, then additional technology-enabled smartphone apps, et cetera, that we have are augmenting the mentoring in that capacity. In addition, two other pieces worth highlighting is that in-person mentoring has been really, really interesting through partnerships that we have and we're developing with home care agencies to be able to activate home care workers, specially trained to go in the home and address and be kind of the extension of the remote support in the home, as well as incorporating referrals and one-on-one expert consultations in a way that really makes sense to the patient and makes it easy for the experts to be able to play their role. Now, we have many, many tracks, but one I wanted to highlight for this presentation was focused on something we developed called Peer Act, which came out of Dartmouth, which is focused on these mentors which stands for Peer Delivered Brief Acceptance and Commitment Therapy, which is an evidence-based approach to reduce loneliness and the feeling of loneliness that comes with it. And this is something that is paired with the chronic disease mentoring. So we're not providing loneliness directed support, but realizing that if loneliness is an issue, which as a quarter of the time it actively is, then being able to allow the mentors to deploy Peer Act alongside of the chronic disease coaching and mentoring that's taking place. And then one important piece for us in Critical is that per partner that we work with, we are utilizing the resources that they put together to be able to really get the patient what they need when they need it to address the underlying social needs. And so some of our partners use tools like a Now Power and Bertha. And so we're part of that system, utilizing those tools to be able to, in some cases, activate those CBOs. In other cases, we have a direct relationship with a CBO where we are, they're part of our HIPAA compliance kind of network, and we're able to share referrals even more seamlessly, et cetera. So there's a lot that we do, and that varies by local context, but we're doing a lot to have this remote workforce of mentors not be something over there and referring out, but really kind of fundamentally extending the existing team's reach and then utilizing those available resources. And so again, it's free available resources in the community. It's premium resources that we can add in terms of a pharmacist or nurse or a housing specialist, as well as resources that exist within the health system or health plan already. And so our platform is our care coordination platform is one that helps support these various pieces. So really, I think to end on, I think one thing that we've seen is that this type of approach is getting broader and broader awareness and recognition. We were recently recognized by the American Diabetes Association as an accredited DSMS, Diabetes Self-Management Support Provider. CDC gave us full recognition for our diabetes prevention program. We've launched with Medicaid plans like Health First and Metro Plus, both in asthma and diabetes. And then I think during this time, especially with COVID, with everything going on, it was an honor for us to be recognized by UCSF last year as a part of their Health Equity Accelerator. And so I will essentially summarizing what we've talked about today is our goal is to be able to develop, deploy, and manage an empathetic workforce of mentors, these remote community health workers for you to really extend your reach. We want to be thinking not just about the social determinants, but kind of everything together and really managing it so that it's not a heavy lift for any team. And then activating your clinical staff so that they can operate at the top of their license and letting the mentors do what they're really great at. And then really driving results, because we want to be able to prove the efficacy, prove the clinical outcomes, the cost savings, and then even partner with systems so that we're on the same side in terms of even financial risk. So with that, I know if there's any questions in the couple minutes I have left, happy to answer now, but also through Q&A, and feel free to email me as well. So thank you.